The authors have no financial interest in any of the products mentioned in this video. Deep lamellar keratoplasty has gained wide acceptance as a preferred surgical modality for treatment of corneal stromal opacities and ectasia where the underlying endothelium is healthy. The most popular technique is the big bubble technique invented by Anwar and Takeman. This technique has a long and steep learning curve. The big bubble is de-roofed using a 15-degree disposable knife. Viscoelastic is injected to push the Descemet's membrane away from the stroma. The posterior stroma is divided into 4 quadrants using blunt-tipped Vanner scissors. The Descemet's membrane is bared and a lamellar donor is transplanted. There is also a risk of inadvertent DM rupture due to accidental full-thickness puncture. Microperforations of the Descemet's membrane can occur during any stage in surgery, particularly during deep stromal dissection. Macroperforations such as this, in which the peripheral Descemet's membrane is ruptured, are very difficult to manage, and they'll often need to be converted into a full-thickness penetrating keratoplasty. If the needle is not deep enough, the air enters intrastromally, creating opacification of stroma, without separating the Descemet's membrane from the stroma. However, the big bubble can be achieved by introducing the needle deeper into the stroma from another site. This case is a 26-year-old male with a macular corneal dystrophy. He has had a successful penetrating keratoplasty in the other eye 2 years back. A partial thickness definition is done to remove the anterior stromal layers. The first injection, done using a 30-gauge needle, resulted in entry of the needle into the anterior chamber. Anterior chamber was decompressed by doing a paracentesis. With the second attempt from another site, a type 2 bubble was achieved with minimal corneal emphysema. Using a 15-degree disposable knife, de-roofing of the big bubble was attempted. Another attempt at puncturing the bubble perforated the Descemet's membrane with resultant flow of aqueous. A blunt cannula with viscoelastic was introduced into the space as an attempt to separate the Descemet's membrane from the posterior stroma. However, this resulted in the viscoelastic entering into the anterior chamber. So a manual dissection of the stromal layers was gently carried out. The frequent escape of the air bubble from the anterior chamber through the perforation had to be dealt with using a 10-0 nylon suture application. At this point, a small portion of the unescaped air in the big bubble was identified. The roof of the bubble was punctured. The viscoelastic was injected into the space to separate the stroma from the Descemet's membrane. Thus, the lost bubble was retrieved. Stromal dissection was carried out in multiple quadrants, exposing the underlying Descemet's membrane. The area which was not separated in the periphery was dissected manually to facilitate suturing. After complete baring of the Descemet's membrane, the suture applied to the perforated area was removed along with the residual stroma. A same-size donor graft is applied to the bared Descemet's and sutured. Thus, this case was successfully completed. On the first post-op day, the graft was compact and clear. There was no evidence of double anterior chamber, which was confirmed with an anterior segment OCT. This case is shown to highlight the need to retain the recipient endothelium wherever possible. In case of lost bubble, identifying even a small air bubble can help us to retrieve the big bubble and complete the DALC without converting into a full thickness procedure.